Do I have anybody on telephone? Let me see. And that's kind of hard. Okay.
I
So,
am, Miss Gordon.
oh, you are? Oh, okay. Because it normally shows me. So, is that Rebecca?
It is.
Okay, all right. All right. So, you may not be able to see some of our stuff, but you can hear Rebecca. And
Yeah, I saw y'all earlier, but I figured it's better that way I don't have to lose anybody.
okay, all right. All right, you guys. So, we need to get rocking and rolling. We have some announcements basically, or I call it housekeeping kind of thing. And one of the biggest things hanging over your heads, our heads, is this psych boot camp. So we finally got a date, and prayerfully it's going to keep working, and you, as many of you get there as possible, so that we can just get this done and behind us. Okay, so most of you have got math behind you, you've got psych clinical behind you, so we need to get psych boot camp behind us, and we will make it as fun as possible, since we try to do this normally before the clinical, but it's after the fact. So except for one group of you that still have clinical to do. So psych boot camp dates, y'all ready? It is 9/14, and that is a Monday, from 12 to 5, but we anticipate being done earlier than that, because I don't know if it's just people absent, because I see 36 people here between both sections, El Centro and North Lake. So I thought we had a total of 40 something students. I know that I have
44. We have 44.
44.
Yeah.
Okay. All right. So I know that I have like 16, I think, at El Centro. So sorry, North Lake. Yes, Alexei.
Is the psych boot camp online?
It will be virtual. Yes, ma'am. I didn't add
Okay.
that. Thank you. Great question. Virtual. Yes. So we will send you guys in and out of groups, kind of like we'll do today. I should type this in instead of writing, but I want to write. Yes, ma'am, Fatana.
Hi, Ms. Gordon. Can
Hi. And when you guys talk,
you
if y'all
you talked about that become a David Road?
uh-oh, I'm sorry, huh?
Sorry,
I didn't hear you.
sorry, I couldn't. I lost you. I lost you for a few minutes. I couldn't hear what you said about the clinic, the virtual boot camp, and you wrote those dates or that number on the screen. Can you repeat that part if you don't mind?
Yes. So the date is Monday, the 14th. And the time is from noon to 5. We'll probably be done a little bit earlier, but we'll just put that date that time frame for whatever. And it's virtual, and we will send, yes, it'll be via Blackboard Collaborate, yes. And that's all about it, really. We have 4 sessions, therapeutic communication, I know y'all hate this, but we got a case study in the VSIM, because the case study in the VSIM has to do with, usually when we do a boot camp, we have to have kind of like a simulation kind of thing. So those are our 2 simulation kind of things that we would have to do. And actually, we did try to make it as a follow-up to the VSIM that you're doing for 2360. So it is the other half of him, of David. So you'll already know about the patient, and it's just following through. And so one of the instructors will guide you through that, and we'll ask questions and just be done. So I think the other thing is, and I think I clarified for most people, there was nothing that you had to do for this class. We used to have a case study before you came into class as a entry into class, but we didn't want to do that. We've just done enough, and so we're not doing that. So there's nothing you had to do for psych for this class. So after you have this class today, you are done, and you should be And by the time we finish boot camp, you should be very prepared for your first exam, which will be cognition and interpersonal, interpersonal relationships.
I think that's September the 21st, I think.
Y'all's first exam is on the 21st.
The Monday after boot camp.
Right. And they will be getting with y'all about tests and all of that. I don't think they were going to be doing it online. So can I ask a PNC question? The calendar online is still, wait, hold on. Let me get to the chat. I'm not there. Thomas, the calendar online is still the spring. Yes. So a student has asked me about updating the calendar for readings and etc. so you guys can get ahead. So give me to the end of this week or the beginning of next week to get something done for that, and I can send it out to you guys so you can start ahead of time. Okay, but the class technically, Thomas, the class technically does not open until October 19th. So you won't be able to upload any assignments, anything like that, because the class is not available, but I will definitely be glad to get you a calendar with some readings or whatever. Okay, all right. Any questions about anything else, Alexei?
For the psych VSIMs, are we going to be provided with an access code, or do we have to purchase those?
I think you were
Okay,
supposed
so
to
are
go
you
with
telling
Ms.
me you
Becker.
do not have the psych VSIM?
No, I don't. And I called Lippincott about it because we got them last semester. But apparently the access code we got last semester was only good for 90 days. So they're expired now, and now they're saying we have to purchase it. So I was wondering if we have to buy it or you guys are going to give us an access code.
Did
No,
you
they
contact
are
Ms.
not.
Becker? I think you were supposed to contact Ms. Becker during the summer. That was my understanding.
Right, they are not intending to give you an access code. I hate for you guys to have to buy it. So at this, and some people, for whatever reason, have gotten an extension. So I don't know if you could call and state a very compelling case to get an extension, to just cover these couple of VSIMs, to just cover you guys until maybe like the 14th or 15th.
Ms. Gordon, did we talk about putting them in groups so that somebody in the group would have access to that? Was that part of our discussion?
No, I don't remember that, Ms. Gray. I'm not sure. You talking about us putting them in groups for what? During the virtual
I'm
sim?
talking about boot camp. I'm talking about boot camp.
For boot camp, yes, we got your handle for boot camp. It's just that first part to do that one. I hate for you to pay $75 to do one. And I really wish people could share. But when you share, it's just the other person's name comes up and not yours if you're in somebody else's login. Also, if you didn't have to buy it, it's $99. It's $99, Jessica, you sure? I thought it was $75. So don't get the DocuCare with it. I mean, I think I can work around DocuCare for you guys on that piece, but that would only be for my clinical. I don't know what other people are willing to do. I'm sure Miss Freeman is willing to do it. And then I don't know who else. Yes, it was $108. Dang it. See, it's went up, but that hacks me off really bad. Yeah, DocuCare is separate. So I don't care if you don't do the DocuCare as far as I'm concerned. I'll have you write me a note or something like that. Just do some narrative charting, if you will, and we can get over that. So Ms. Gray, your clinical group, are you willing to do that for the DocuCare piece so they don't have to buy that? So what was 129 for you, Alexa? Was that for, was that for the VSIM? They're trying to charge you 129? Oh, okay. God, I don't know. When y'all go through it, are y'all going through your Lippincott account? I think things are cheaper when you go through your Lippincott account. Contact Lippincott to get the discount link. Oh, okay. So maybe Fatana did that. Fatana, how much did you pay with the discount link? So,
Well, this semester I haven't bought it, but last semester I have to buy some VSIM. So when I contacted them via chat, I told them I'm a student, and they sent me a link, and I was able to purchase it for cheaper. I think it was 74 or something like that. It was much cheaper.
that's what it's supposed to be. So, I mean, you guys make those people work. This is their job, and they need to be able to provide us with, because we've paid a lot of money to them. So we need to make them work for their money. You need not to worry about having them done by the 5th. Okay, that's this week, isn't it? Today is
Talking about Parkland module, sorry.
What'd you say, Ms. Gray?
Oh, I was talking to Miss Gray about the Parkland modules, not the VSIM, sorry.
Oh, okay.
Yeah.
Okay.
I'm just stuck. You know, my hands are tied with Parkland. I contact them every day till I'm really a wart. But we eventually will get those codes. So I think they had an issue with my email. They had a space after the Y and before the @ So I've got that corrected. But I've contacted the contact at Parkland, Stephanie. I contacted her Thursday, Friday. And I think Kim Walls contacted her yesterday. So it hasn't fallen in the cracks. We're just working on it. So it's and they take quite a long time to do. So I have it. I'm working on it the best I can.
Okay, I just wanted to make sure they weren't still due this week.
Well, no, there's no way, you know, because I think they take, you know, quite a few hours. So we can't hold that. You know, they wanted to wait till September the 20th to open up those modules, and we start clinical at 6:45. So that's probably not going to work. But I have forwarded my concerns, and so we'll be working on that, and I will be in touch with you as soon as possible. Thank you for checking back with that.
Thank you.
Okay, did you guys see Marissa's post? She chatted with Lippincott and asked them directly for a free 30-day extension. Did they do it, Marissa? Okay, so for those of you that don't have it, I would encourage you after today's class to just do it, to do this chat with them, like Fatana has done, Marissa's done, and ask them. As people say, you have not if you ask not. So all we can do is ask, and what only if you have not gotten it already. What does that mean? The discount, Fatana? This morning they gave me 7 days. Okay, 7 days covers to get that first part 1 done. Because in boot camp, Mrs. Marjorie is going to share her screen and do everything with that VSIM. Or we have to cut it short. We're not going to be able to do everything. We're definitely not doing any documenting. So 7 days should suffice. I can crank out a Slack VSIM in 7 days. Go Thomas, yes. So go for that. Can everybody that doesn't have it, will y'all try it? Please try that. And promise them you won't ever ask for anything again, because you're not. You're going to be gone. Yay. Try it through the chat. Okay. Yeah. Or if you can get them on the phone, fine. I think somebody had told me once they were on the phone for 4 hours with them trying to get to, I guess, the right person or something. Jocelyn says they said they were going to talk to the representative from ECC. I did this morning. They were only giving me 7 days. 7 days is good. If we can get that 7 days. Okay, you guys, we don't want to spend much more time on this. Y'all work on that. If you need to have some kind of verification, I did have one student do that where the representative said, your instructor needs to say you need it. I'll be glad to say you need it, okay? We'll definitely be glad to say you need it so you can get this done and get it behind you. I am so that was the other thing I need to tell you guys. I got 36 of you still. I don't know where the other people are, but I wanted to let you know, if nobody else has let you know, and me and Ms. Gray right now want to let you know how proud we are of you guys that you got this far. I know back at first semester you were wondering, how can I do this? Am I going to get this? Can I get through this? It's like, what did I get myself into? Can I get it through it? And you are here, and it got here before you need it, before you knew it. So very proud of you, and just want you to just be counting down. And as you get done with one thing, it's like, that's another thing behind me, and just start throwing things behind you, and then you're going to be done before you know it. So
absolutely, we are proud of you. And first level seems so far ago, long ago, but anyway, you're there. You're almost there. You can smell the end. So congratulations and keep on pushing.
okay, I still see several chats about this going on, so you guys just do whatever you feel like will work. Some of the students have got better with chat, some got better with, I don't know. So just
Yeah, we need to move on and get back with them somehow or another.
okay.
Communicate with them somehow or another regarding this. So maybe we can do that in another format, but we need to move on with class, I think.
Yeah.
So save all your questions, email us. Probably email is the best. So we'll follow up on that the best way we can. And use your peers as resources. Some of them seem to be successful, so use your resources.
Let's try things out. Plus the cheese.
Okay. Somebody asking a question?
If they're ordering cheese sandwich or something, they need to turn their mic
Okay.
off.
Thank you.
There's pepper and ketchup in the back.
Thank
Y'all
you.
enjoy.
Put your mute on, whoever that is. I don't know who it is. Okay, you guys, let's move on. That's a good question. All right. We'll get through DocuCare. I'll have you do written document if we need to. Don't buy DocuCare, don't. Okay, don't buy DocuCare. All right, you guys, there are 3. We are getting ready to just get into this mental health issue. And those of you at Northlake, I've had since first semester, and second, third, I did your mental health, etc. Who can tell me what are the 3 overarching things with mental health patients that nurses are doing with them? You can unmute yourself and talk to me. I'd rather be talked to than, okay, safety, number 1, Kristen, very good. Safety and communication, so therapeutic communication and medication compliance. I am so proud of y'all. Y'all have been listening. Y'all have been listening.
Me too. Yay.
I'm so excited. All right, so now with therapeutic communication, yes, and you guys saw that for those of you who have been to clinical. You saw how important your therapeutic communication is. What you say and how you say it makes a difference in whether you have a therapeutic milieu or a chaotic one. What is milieu? What is the term milieu? If you're going to be a mental health nurse, you got to know what this is. Yes, environment. Do you want, so you as a nurse working on a unit or your mental health techs or whatever, do you want a therapeutic unit or do you want a chaotic one? And I would go to say we all don't want a chaotic one, because maybe I think a few of you may have experienced when it got a little chaotic or a little hectic on the unit, because then that moves to that safety thing that puts everybody in safety.
Absolutely. It's a
We
safety
can have
issue.
some safety issues. Yeah. Jessica.
Hi, sorry. Good morning, Ms. Gordon. I was just
Good morning.
going to ask you what MU was, like M like mom, U like umbrella.
Yeah, let me spell it for you.
You,
Here,
amazing.
let's change colors too, make it somewhat read it. All right, you know what? Actually, I'll type it in. How about that? And I wish we could make this bigger. I don't forgot how to make M-I-L-I-E-U. Milieu. That I is not in there. Milieu. Oh my God, I can't spell right now because I'm on the spot.
I'll get it.
I can't even spell. Maybe it is the I-E-U. It is in a U. The milieu. Yes, there we go. It does have that I-E. All right.
Thank you.
Very good. So that's the word you wanted to see, right, Jessica? Where are you?
Yes, thank you so much.
Okay, good. All right, so that's the term and the nurses is responsible for the milieu, believe it or not. The nurses, I hope that you guys saw this in your psychiatric clinicals. And I've had in the past where they said, like, no, the nurses didn't do anything. Well, that's not the way it's supposed to be. The nurses really do control that whole milieu. You know, we're keeping things kind of moving along, getting their patients their medications, making sure they're attending groups, and the nurses in the group. 9 times out of 10, that's the way it was when I grew up. I don't know about Miss Gray, but when I grew up, the nurse was just all involved in all of that. I didn't see it as much even when I was at the clinicals this time, and I think it depends on the nurse. So, but for the most part, always be a nurse worth your salt if you're going into mental health, and you are the one in control of that.
So
Ms. Gray, you have any comments?
you're in control of keeping your patients all safe. You're in control of keeping your staff safe. And so that's a real skill to keep everybody all safe.
Okay, moving on to the second tenet. So medication, why is it up at the top there? Now, even our med-surg patients, we can give them medications and whatever, but it is so important for our mental health patients because they cannot function without the medication. You know, they're not going to be able to have a normal life, or they're not going to be able to, you know, have good interpersonal relationships. That's why this is involved in that, or that's our concept basically. So because it's so important. So a lot of times while they're in the hospitals, because they've got off of that medication regime. So we need to make sure they are taking their medication. It is vital for mental health patients.
Ms. Gordon, I'm sorry, go ahead.
Okay, no, I'm done.
Ms. Gordon, I was just wanting to read a little quote from Beiderbecke. And actually, this is for I'm got the wrong book. But it's okay. It's what it says. It's important that people that have mental health diagnosis, when other things get ignored, you're not seen as a whole person. The separation between systems that happen is really detrimental because you have this whole group of medically oriented people who feel like that they don't know anything about the psychiatric stuff, that it belongs to someone else, but you are there. It's a big gap in between. So that just kind of gives you some idea about that and how we have to be a psychiatric nurse in whatever area we're in, neonatal, OB, med surg, we're still psychiatric nurses and we have to see the patient as a whole.
Yes. All right. So along with coming with the medication comes the biggest issue that we have with them, and we just talked about it, that whole compliance thing. As it relates to NCLEX, since you guys are almost there, when you get mental health questions, it doesn't matter what you know about mental health, 9 times out of 10, the bottom line of what the question is kind of saying is asking is about keeping the patient safe. So when you're answering even therapeutic communication questions or questions about mental health patients and their medications, it's about safety and compliance. Is the client safe, or can we get them safe? And then is the patient compliant with medication? And then whatever you know about the medication and safety and whatever, you could get tons of therapeutic communication questions about them. So you guys tend to not like those. And so that's some of the stuff we'll be doing in boot camp. It's talking about them therapeutic questions or just playing with some or whatever. All right, so moving on here and talking about NCLEX, so I'm going to take this down, Ms. Gray, and put up, let me make sure I have it up first so that it's in my PDF, that's where it is. Okay, so since you guys are getting ready for NCLEX, and I know my North Lakers know this, but if this is not a rocket science question that I'm getting ready to ask you. Oh, stop it. All right, so these are the NCLEX client need areas, which your NCLEX is all about. You have to be above in all 8 of these areas here, which is 1, 2, 3, 4, 5, 6, 7, 8. You must be above to pass in all of them. If you're less than 1, if you just are near or below in 1, the whole thing is done, and you have to do it again. So where does all of the mental health stuff that you've learned from first coping all the way to now and interpersonal cognition, etc., where would that content fit in the scheme of NCLEX? You guys can type it in or blurt it out or whatever. Or maybe I can pull names. Y'all know what? I put names in a bag so I can pull names. I don't have all of El Centros, just my clinical group, because y'all are all I know. Okay.
That is correct. It is the psychosocial integrity. You're exactly right.
Yes.
And look at the percentages of that. Look at the percentages of that you have to do to be successful.
So, and let me break that down for you. It is not a lot. So, and this hasn't changed even with the new test plan. We had a new test plan, and oh, I forgot now. I can't even think. But very shortly ago. It hasn't been long. Psychosocial integrity gets a percentage of between 6 and 12. So out of all of these percentages here, health maintenance and health promotion and maintenance, which houses all of your OB stuff and growth and development. And basic comfort care, which is all your first level stuff, basic nursing stuff, which is, you know, elimination and all of that kind of stuff. So they say they give you plus or minus 3 in any category. So for these categories, you'll get about 9%. And I like to break it down this way. If you get 60 questions, about 9 of those 60 will be psychosocial, basic comfort and care, and health promotion. So you don't get a lot in those areas. But if it is an area that you have been weak in over your HESIs, and all of your HESIs are your blueprints for NCLEX, you guys, you can go back and compare all 3 and your 4th one that when you take this semester. If you were low and if you were below 850 in this area consistently, it might be a starting point. So that those 9 questions that you might get out of every 60, you will be above in that. to not fail in that area. You certainly don't want to fail in that area when you don't get a lot of questions. Does that make sense? You get your most questions from these, which are your med surg areas and your complications. So these are complications, so black boxes, negative consequences on all of your concept maps, and these are your med surgical problems. And then management of care is the second biggest areas, which is all of your PNC stuff. Okay? All right, that's that in a skinny that I like to bring in. And then we are going to look at our maps really quickly, and I didn't even bring up interpersonal because y'all know we have to show y'all this, but you got it by now, basically. So cognition, process of thoughts by which an individual learns, stores, or receives or uses information. So how does that relate to our patient that has schizophrenia or some of the personality disorders? They got some cognition stuff going on too, but it's more on the mental, the psychosocial side than the interpersonal side, if you will, because all of the personality disorders got interpersonal problems. Let me tell you, they can't get along with people.
How do the hallucinations and delusions fit into that cognition? Are they positive or negative?
I have to see the chat.
Tell me the difference between hallucinations and delusions.
A hallucination is something that you see or hear that's not there, and a delusion is a thought or idea.
Okay, that's a good answer. So hallucinations always have to do with the senses: seeing, hearing, tasting, feeling, and smelling. So we don't often see a lot of people that have hallucinations of smelling, but perhaps sometimes they would tell you they can't go in that room because they smell a dead body. They may feel like they have things on their skin. But more commonly is the visual and the auditory hallucinations. They hear people talking to them. They see people that we don't see. So hallucinations always have to do with the senses, where delusions is a false fixed belief. They believe that they're Queen of Sheba, or they believe that they're President Trump, or whatever it may be. It's a false fixed belief. And there's nothing therapeutically that you can do to talk them out of that delusion. The only thing that changes hallucinations and delusions is one thing: medication. There's no other way to change that except with medication. So when people are compliant, they don't have hallucinations and delusions, or if they do, they're minimized. But if they're off their medications, then they have auditory and visual hallucinations. And so and as people become less compliant and more brittle, then it's harder and harder to get them to respond to those antipsychotic drugs.
Okay. All right. So you guys know if these two boxes, the attributes and the antecedents, are within normal limits, are we giving nursing care, true nursing care? Remember, when these dotted lines go this way, it can go both ways. So if everything is within normal limits for my patient, what kind of nursing care am I giving? Or what am I doing? Okay, maybe some preventative things. And what kinds of preventative things would those be, Lowena? So we're keeping the patient safe by what preventable things? monitoring and safety, and we're perfecting from self-injury by keeping the bed low, making sure the call light is on. Yes, we can administer medications, but that's kind of a real true nursing thing that we do. Yes, we're going to give them their routine meds to make sure that they stay safe. But keeping the calm environment, a clean environment to prevent the injury, and so great. But other than that, when one of these things is out of order or something is not, so nurses are always looking for problems within these areas, because that's when we're truly doing some intervention for the most part. We're going to always keep them safe. We're going to always keep those bed low and call lights and all those kinds of things near. So that's what this whole little area about. And of course, when you guys are in clinical, y'all don't have to do no more concept maps. Yay! Woo! That's a happy dance, right?
That's a happy event. So when you have a patient, particularly a patient that's schizophrenia and hallucinating or delusional, or even a bipolar patient that is agitated or acting out, and therapeutic activities are in groups, we always want to, the first thing we want to do is redirect. We want to redirect that patient, just like you would with a child. The first thing you do is redirect. And then if they don't respond to the redirection, then you may have to confront the behavior. But we always want to go to the least restrictive alternative, and the least restricted alternative is to redirect that patient back into the activities or to the group.
Right. Because I think most of you want to remove them. It's like, oh, take them to their room or put everybody else in their room. Well, not necessarily. Because if I don't have anyone to be in that room with them, I definitely don't want to take them to the room. Now, there might be times that the patient has really gotten out of control. But if we can de-escalate it, like Ms. Gray was just saying, with our words and redirecting and keeping them engaged there, that's what we want to do. And then if it just gets out of control, then it's easier to move other people than it is to move that patient. Does that make sense? All right. Am I cooking with oil with the 36 of you? I always got to make sure that everybody can see as clear as mud. All right. Good deal. Okay, so, cognition issues are the main components that causes cognition issues are people have brain development problems, they've used substances or et cetera, and these things. So I'm not going to go through all of that with you guys because y'all seen it a gazillion times, so I'm not going to go through all of that. But of course, this is the nurse's job, is these things here, is that we're doing our interventions to come out with these positive consequences versus these negative complications. It is your job. That's that area that I just showed you, is to reduce. That's what this area is all about. If I go back to this, reducing the risk of potential for complications or other problems on top of the problem that you already have. Your job is to make sure that those don't happen. So that's what this, sorry, let me get back here to the thing. That's what these are. You want to make sure that they don't happen. That's a nurse's job. That nursing care box over here, it should not, all of my interventions should make sure these do not happen. And then your interrelated concepts, our body is so intertwined and interconnected. My last class was with first level, so I had to go first foundational level to fourth level here. So just trying to show them how everything is connected, all the way from the brain to the toe. It's all connected. So when one problem is affecting another, it can affect, so cognition can affect my interrelated concepts as well as my interrelated concepts affecting my cognition. So you guys can think through those. We're done with that. We'll look at interpersonal relationships.
When we think about the patients that are inpatient, the patients that are inpatient are always there because they are unsafe to self or others. So when we look at the negative consequences, we're always going to look at what kind of harm they could do to themselves or to others. And we look at positive, we see that they are able to handle those things and that they're not harmful to themselves or others. So again, it's just a safety, it's absolutely a safety answer.
And NCLEX is all about safety, you guys. Y'all can never err on the side of, you can never err on the side of safety. When you can't think of anything else, or if a question seems to stomp you for whatever reason, it's like, step back for a minute, clear your mind, and take some deep breaths and regroup and come at that from the safety aspect. What is the absolute most safest thing I can do for this patient at this point? And you may or may not like the answer. Huh?
Very, very good advice.
Yeah, it's like you might not like the answer, but it's like, out of all of these, this is the safest thing. Go with it, and I guarantee you will be right 9 times out of 10. 9 times out of 10. All right, so hold on one second. So interpersonal relationships, we just gonna hit that real quickly. Facilitating are, let's make it a little bit bigger here. And then we got to get into the fun stuff. All right, so interpersonal relationship factors that facilitate and or impair effective social association connections, affiliations between 2 or more people. Now, the people that we're going to talk about today, it is definitely all interpersonal. So we're going to start off with the violence kind of stuff, and we can see that they're having violence and abuse and rape and all those kinds of things because they do not have good interpersonal relationships at all. For one reason or another, their psyche has been seared for whatever reason, because normally when people have had a good environment, a good upbringing or whatever, we are naturally carers. We care about people. But then things happen to people and they start to just lose that, where they don't have good personal relationships. So usually when it comes to these kinds of questions, just think social. This whole thing is really a social thing. So if I'm not wanting to be around people and withdrawn in those things, then I have a social problem. And it could be stemming from my psyche or my psychosocial, making it a psychosocial problem. All right, so not going to go through those. Really, we just talked briefly about that because we got to get on to other stuff. And it's getting close to a break time. You guys might be tired of sitting and listening to us right now. All right, so let me put this up right quick. I try to keep you interactive, so I want you to do this for me right quick. So I'm going to need you guys to utilize your phones to do some interactive things with us and me. Where is it? Okay, here we go. So can you, with your phone, I got a picture that I'm going to put up, and I want to create a word cloud of how you think and feel about this picture. So where is it? Let me just pull it up first. How about that? So in your phone, you can just go to your browser, and I want you to put POLEV/Unigordon995. And I'm going to find my picture and put it up here. Oh.
Miss Gordon, is this a dog?
Is what a dog?
That picture.
No.
What is that?
You can't. Well, that's okay. I want you to put in what you describe your thoughts about this picture. That was.
Oh my goodness, I blew it, didn't I?
It's okay, and you can do this too if you want to, Miss Gray. Now, if you want to text it, you can. You would have to put in this number and text Unigord 995 to it. Legit picture GB's terror gives. Wait a minute, I'm losing some of you guys. There it goes. Here it comes. Shock, scary, panic, oppress, anguish. Shock and scary, those are the big caveats. So maybe several people have typed that. Anxiety, fear, panic, frightened. Anguish is good. I really like that. Okay, so frightened has come across a lot. These are the big ones. Are kind of, there's several things in there. I don't know how many people is responding yet. Terror and isolation. I love all of these words. But I like to show this picture because it really does set the scene for all of the people that we're going to talk about, and really particularly for our schizophrenia person. So let's describe this a little bit. So I would say 9 times out of 10, mental health patients feel this way consistently. And if we're honest, there are times that we feel like this, don't it? I'm going to be honest, I have a lot lately. I just feel like it's nowhere for me to go. I feel closed in. I feel trapped. It's not maybe as distorted as this. And some of you guys may have felt like, oh my gosh, maybe it's that guy. It is not Macaulay Culkin, I promise you. I don't think,
particularly with COVID right now, I think people are feeling this maybe more so.
Yes, exactly. And or just really, we calling it 2020. Everybody is so ready for 2020 to be done. It's like if one more thing comes about in 2020, we just don't know what we're going to do. Do you guys feel like that? And hold up, let me poll you on that, okay? Just a minute here. All right. We'll just do yes or no. Well, I'm going to just ask you this. Yeah. Stop, girl. Okay. Okay, yep, you're over it. Good. All right. And I'll put this back up to just have a little background. I hate that. I don't know why it does that whole cascading effect when you're sharing. So you guys can just click yes or no. And 17 haven't responded. I'd like to hear from everybody. Make sure y'all ain't fell asleep on me. Can you take anything else happening in 2020? I can't ask it any better than that. Do you feel like you just would pull your hair out if anything else like happened worse than COVID? How would you feel if we had to go back on shutdown? That kind of thing. Okay, so maybe 12 people don't know how to just press the yes or no, but it's about what and what. So some of you are okay, you can, it's like you just gonna handle whatever comes, right? Like if it comes, okay, fine. But my point of the whole thing is that these patients, and particularly our schizophrenic patients, feel this way all the time, where they just cannot function because something is always happening, or they just feel so closed in, panic and terror. because even many of you watched The Beautiful Mind, right? Allostatic load is too high. What does that mean? Good movie, yeah. So even when he got better on his medication, he had to check his reality constantly, didn't he? Does anybody remember what question he would ask if he wasn't sure that his mind was working right? Did anybody catch that? And I'm going to just stop sharing for a minute and then I'll come back to it because that cascading makes me crazy. Let me get over here and see what y'all said. Can you see that person? Yes. Yes. And there might be times we have to check our sanity, right? I don't know about you, but I have to check my sanity a little bit. It's like, did I just hear that or did I not? I don't know. Or I heard something I thought I did. I heard something, but it wasn't anything. It was just kind of like on my mind. But that was beautiful. I thought that was an excellent portrayal that they put in there, that these people have to check their reality consistently and constantly. It's starting to storm here. Hopefully, yes, Luana. I hope it doesn't go out either. We're getting dark clouds where I am right now. Okay, so that's why we need to move on. Okay, so we're going to start talking about, we're finished with that poll. Yes, Luana.
I had a question about The Beautiful Mind and something that we were talking about earlier about how the hallucinations and delusions, that the only way to fix them is the medication. So in the movie, John Nash, he was on the medications for a while, but then he wasn't on them, but he was sort of doing the reality checks, and he was like, he said like certain thoughts, like I just don't go there, like I don't indulge in certain thoughts because that'll spin me into the hallucinations and stuff. And so he just sort of learned how to manage how his brain worked in a sense, even though he wasn't on medication.
Some of that is for the movie, and some people can, maybe just be a combination of the medication and a little bit of mind control. But for the most part, people that have schizophrenia are not able to really manage that very well. So, that really does kind of involve medication and some kind of therapeutic counseling, that they can maybe do a combination of those two. But again, it's compliance, whether these people are going to comply to coming in and doing, group therapy or even individual therapy. They're just not compliant. So sometimes with a combination that could work, but I think a little bit of that was the drama of the movie.
Okay.
Maybe to emphasize.
Because I looked up he said, John Nash anyway, he said that in the movie they implied he was still taking medication, but he said he stopped taking it.
I think some of that again is just the movie, but what we really have to know is that they have to be on medication. Very few schizophrenics are able to manage that. I mean, I talked to doctor, his name is Dr. Freeze, and he's a psychiatrist, and he is schizophrenic and has been taking meds for a long time. But even with his knowledge, he still has to be on medication. So, and I'm sure he does some therapy on the side too. So maybe able to reduce the amount of antipsychotics, but seldom are people that have schizophrenia able to really manage that on their own, just with mind control. So some of that was just kind of the drama for the movie, but the emphasis is that these people need to be on antipsychotic medications and be compliant in order to be successful in the world.
Right.
And I think for John too, now he was brilliant. For him, I could see him being able to do it because he was such a brilliant guy, but for the average Joe Blow, as Ms. Gray was saying, they're not going to be able to do it. They're going to need some help, and they're not going to be able to have any mind control. Yes, it could have been embellished in that movie, but I really think he was just absolutely brilliant and could, once he got his head wrapped around certain things, he could kind of control those things, but along with the medicine, and then, you know, just when he wanted to cut back on it. But yeah.
Good questions. Good questions.
Yes, exactly. Okay. True. Yes, he was very unique. All right. So we're going to start with some violent stuff to just get on that. And I have to do a disclaimer with interpersonal relationships and violence. So these subject matters sometimes are so sensitive that they can trigger things maybe within people, because you never know in any crowd of people who has endured what. So I just put the disclaimer out there. If this tends to trigger, if it triggers anything within you for knowing someone or, you know, yourself, whatever, just be able to, you can just chime out if you want, and then if you need to debrief with Mrs. Gray or myself, please do that, because, you know, I can tell you it's very disheartening for me talking about this stuff. You know, I'm a pediatric nurse, mental health pediatric nurse. And when I talk about children being abused and hurt, and or anybody really, but particularly children, I get very emotional, and I can almost want to hurt people sometimes, or I wish them under the jail forever, and those kinds of things, because it just triggers such an emotional response. So that's the disclaimer, basically. All right, so I'm just going to pull the list up, basically. Our PowerPoints are so expansive, you guys, that I don't like going through them and using them. I think most of the time we can talk about this stuff with short little things I use, but we're just going to talk about this stuff from just possible. All right, hold on a minute. Let me get this again where I can share it so you can remember what the exemplars are. And on this portion for exams or anything like that, you would probably get more questions, and it's going to be sometimes therapeutic communication kinds of questions that we have to ask about these things, maybe signs and symptoms somewhat, and definitely interventions. Hold on, sorry about that. Definitely interventions. So, we'll start with, and maybe when I have this up, I can't see questions. I thought I heard something in the chat. I heard a click or something. So maybe Miss Gray can do that if I'm talking, and then let's see. Or you guys just chime in. Which we haven't had yet. You haven't had what, Lowena?
Oh, I was just asking when we had to turn in the concept map for the Beautiful Mind. And she said first.
Oh, that's at Parkland. Yeah.
Oh, okay. Okay.
Yeah.
All right.
Don't get ahead of yourself. We'll just we'll make it.
Okay.
First clinical day.
Yeah.
I hope we have a clinical day.
Yeah, we try not to make that stuff real difficult. So just and it's gonna be your last one. Just think about that. I think that would make me happy. I guess I better turn some lights on. It is getting pretty dark out here.
Yeah, we're getting there. So don't stress over that. You know, blessed are the flexible; they won't get bent out of shape. So I'm willing to work with you in any way we can to get through the Parkland clinicals, and we will do it one day at a time.
Mm-hmm. Okay, I had a condensed PowerPoint with all of my domestic stuff in it, and we're not going to ever test you over statistics, but you guys know domestic violence is like high. It's up there. And who can tell me what has happened during COVID with domestic violence?
Absolutely increased, because we have so many people that are isolated and people are getting anxious. Yeah, definitely increased.
Yes, it's increased. And to tell you the truth, we don't have the numbers. They're not going to have the numbers probably until this is all over. They're not going to have the numbers on the amount of suicides and how depression, anxiety, and all of the mental stuff has compounded from on top of the physical stuff. So we just don't know, but I can tell you it has doubled probably what it was. So the statistics, the latest statistics were 1 in 4 women. So women are the number one people that are normally battered, if you will. And then please don't forget that men are included in any of these. There is no social boundaries for abuse and domestic violence and all of that. It doesn't matter where you live. You can live in Highland Park, I say, because I always use the case of this Highland Park family with all the money in the world and still having issues, and where this man, and I told this story a couple of semesters back, and the guy in the class actually knew the man. So the man was so whatever about his whole divorce or whatever that he, to spite his wife, he killed his children on the phone with his wife on the phone. He had them over this Christmas break, and this was in Highland Park with money, and you know, they can buy the world or whatever. So there are no social bounds. It doesn't matter where you live. You can be the poorest of the poorest. You can be the richest of the richest. You can be anywhere in the middle. It doesn't matter, including domestic violence. Domestic violence can be right next door to you and you not know. A lot of these issues, you know, sex trafficking and whatever. I have friends in Capel, and right next to them, they were doing prostitution right out of the house next to them. So it just has no bounds. But women are the most that are battered, and of course men are battered too. And usually with battering, it leads to severe violence on the most part. Because what are the issues that... Sorry?
And then the children are abused as well, so.
Right. The entire family can be abused. And I think our culture is so messed up today that some people don't want to just, you know, go away and hurt themselves, that they will take the family out and then take themselves out. So that more of that is happening more than just killing one person. So they will batter the wife, and then, you know, then at some point, if that lady doesn't leave, so who knows the cycle of abuse? And I tend to put these together, so please forgive me if I'm talking about domestic violence and then get into with the whole abusive situation, because it just goes hand in hand. Miss Graham, I'll let you read those rather than me trying to take this down and look. Honeymoon phase, okay. So you got these different phases.
Mm-hmm. I'll never do it again. Mm-hmm. Tension builds. I'll never do it again. I'm sorry. And then the tension builds again, and they abuse again. So it has a very definite cycle, and people get involved in that. Women are so afraid to leave because they're afraid that the abuser will hurt their children. So women tend to stay because they're afraid for their children. So what you have to really figure out is that you have to give them some kind of an alternative plan. So then you may have the plan, give it to them 100 times and they don't use it. They need to have the resources of where they can get help. They need to have a little bit of money, and I'm talking about just enough for dark trail, you know, the dark ride or something. And then when they leave, when they finally do decide to leave, they need to be sure that they take their children's papers, their Social Security cards, and their vaccines and those kinds of things, or otherwise they can't get them in school. So we're seeing a lot of this again. You know, it's all coming up because people are being abused and they have no place to go. So our homeless shelters, our domestic homeless shelters are very overrun right now.
Mm-hmm. Mm-hmm. And this can take years. It's very hard for healthcare personnel that work with these families a lot to just, you know, see that cycle happening over and over again where the lady won't leave. It can take years. I've had a family when I was a school nurse, that it took her about 3 years to make a move. And when she made that move, she didn't make it. You know, the kid used to come in my office every single day because he had muscular dystrophy. But, and she couldn't let him know because she knew he would tell me, and that would put both of them in a position because she knew when she made this move, the father was coming straight to my office because I was that close to the family or they were that close to me or whatever the case was. So when it happened, and he did exactly, she knew him like a book, and I had no idea. So she was able to keep me safe or keep me from whatever having to be in the middle of all of this because she knew that husband would come, and he just came and cried and begged, and did I know where they were? And I had no clue, so I could be totally honest in the whole situation. So it's just devastating, and it is just a hard thing to deal with. So Miss Gray gave you the plan. Basically, it's just about you knowing signs and symptoms. So what signs and symptoms can these patients have, all the way from the adult to the child, if they're being abused, leading to, you know, the violence part or whatever?
Let us hear from you, students. Bruising at different stages? Absolutely. That's good.
Yes.
Head injuries?
Yes. So we'll talk about that shaken baby syndrome in just a minute. That is another form of abuse with the baby.
Hemanditis? Burns?
Yes. And the key is with this is that the injury is never consistent with the story. So, oh, she fell down the stairs or she hit her hand on the door or whatever, and the injury doesn't look like it was something that just came from, you know, hitting on the door or whatever. Like cigarette burns are common for kids, and of course bathroom scalding burns are common for kids. For the lady, she is going to be trying to hide bruises and etc. with sunglasses and, you know, clothing, just more clothing maybe that she's needed. So if she has neck injuries where he's tried to choke the life out of her, she might have a scarf on, because sometimes if they didn't kill him that time, so eventually the lady does get killed at some point if she just won't leave and doesn't leave in a timely fashion. And, you know, this is very close to me, this, you guys, because actually Miss Gray was with me that day. My son-in-law, his brother was killed by, so this can be sex on, same sex on same sex, you know, opposite sex, it really doesn't matter where his partner killed him from, you know, them going through a divorce or whatever, and he felt like he was safe. People were asking him, do you feel safe, blah, 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 and no, and he, the next thing he knows, he's gone. He's just gone. So it's very horrific. Pick up on the signs. It's hard to question them, and the lady will always protect the perpetrator for a little bit. Oh, he didn't mean it. He didn't. Poor Abrielle. She keeps losing connection, and the wind is going crazy out here in front of my house.
So just always be sure that you have, as an intervention, that you have given this person that's being abused, that you have given them a resource of where that they can get help. They may not use it, but just keep giving it to them so that they know that there is some help out there if they reach out to get it for themselves and their children.
Very good. So you guys have great answers. Look like you've done great reading on that. And, you know, this, you don't even have to do a ton of reading on. You got, you know, this stuff happening in the news every day, but we really want to just hone it down onto what the nurse is going to do. So, you know, sometimes when people are being abused or in domestic violence situation or whatever, one of the other biggest thing that nurses can do is we have to really do that active listening and be totally non-judgmental, because we'll talk a little bit about that when we get to rape, because that person, it's like it's nothing that you could say or do that will fix any of that. Does that make sense?
Exactly right. So we just want to listen as much as we can. We have to remember therapeutic communication and not giving advice. You kind of have to almost bite your tongue not to give them advice. So you just have to listen and give them resources. So not ever giving advice when you should and you need to and you could have, and because none of that is helpful.
Right. And silence is golden. It's okay to be silent and just be present with them. Just knowing that you're there is enough for them sometimes. It's the exact same as if a patient received a cancer diagnosis. It's nothing you can say or do that's going to change anything. So being silent and being present until the person is ready to talk is beautiful. It's perfect. Until they're ready to talk and discuss it, it's just nothing you can say. Yes, I read that too. Okay. What? Oh, yeah. Are y'all talking amongst each other? See, that's the hard part about trying to follow conversations. I read that reporting for older adults is mandatory because of the age. Make the decision however they should assist with resources. Okay. Okay, all right. So you guys, we've been talking for a little minute. Let's see if we covered everything. We'll come back for the shaking baby syndrome. Let me get to this here. Elder abuse, child abuse. The biggest issues are abuse is about reporting. We can report on suspicions. And 9 times out of 10, we're going to have physical evidence anyway. And so even when it goes to the lady and the violence that she's saying one thing, but we know one thing is something else is going on, we can report that. So with domestic violence and abuse, what are the confidentiality parameters?
It's a good question, Ms. Gordon.
Yeah, that's kind of what I was wondering, because like if they're an adult, they can make their own decisions and they still have confidentiality. Like we were saying in the chat, we just assist them with resources, and if they say, I want help getting out, then we help them, but we can't like make them or anything like that. So what would the situation be in which you actually would like report something?
Okay, well, let me ask you this way. There are 2 times we can actually break confidentiality. What are they?
If they're going to hurt themselves or someone else, or if they're going to be, what if they're going to, like if they're in imminent danger? Is that a situation?
If they're in imminent danger and they are requesting help, then yes, we can help them. We can help either try to get them safe or report it at that point, if you will, because they're requesting help.
I think in the chat, Ms. Gordon, they're talking about a child. So if a child is being abused, then they would be reported to the CPS.
We can report to police if they're in danger, totally in danger to being killed and those things. You can report that to the police. And you guys know the police don't do anything until something happens for the most part, right? They are so scared of intervening in those things, but they will go when there has been a report that, you know, there's a lot of fighting going on and this kid has ran over them and saying, you know, that my dad's beating me. You need to call the police. You can call the police. CPS, you might not even be able to get CPS. And the police will, you know, get CPS involved in it. But there are hotline numbers for CPS, basically, in some places that you can report. Like my little report here, it was saying that when in certain situations, the nationwide hotlines for violence and abuse and those things can receive over 20,000 calls in any given week and month. That's a lot of calls.
That's a lot of calls. So, and I think that the guidelines of this does vary somewhat from state to state. So I think you have to be for sure that you know for sure what your state guidelines are in the Texas Board of Nurse Examiners, what they're saying in Texas. So because it does vary from state to state.
Yes.
When you report and who you report to and how you report it.
Yes, you do have to do your state laws. But in hospitals, if you were a nurse in the hospital in the ER, they would definitely have those guidelines and protocols set up for you. So you would want to know what your hospital, your institution's protocol is for intervening in domestic violence and abuse situations, elderly, young, etc. All right, so I think you guys need to focus when you're reading on signs and symptoms. And by the way, I'm going to send you guys my condensed notes after this. You can have my notes on all of the subjects that just get to the point. And I can't remember if I put page numbers in there to go and look at your specific how the nurse is supposed to feel, or what do we call that? I have it written down somewhere in my notes.
Empathy or sympathy, maybe, or is that what the word should have
No, that's not the word. I was wanting nurse awareness. Your awareness. What is the awareness you should have? A lot of these patients, when we get to personality and back to schizophrenia and that stuff, they're very manipulative and those things, and you have to be keenly aware of how you're feeling so that you can interact appropriately. Okay? All right, we're going to take a little break here for a minute, come back and talk about this. My mouth is dry, and I don't know if this light over my head is getting a little light or something. I might need to grab something to eat. So let's take a 10-minute break. So it is 12:23. Why don't we come back at 12:35? And I will put the break slides up. We'll come back at 12:35.
I'll put it up.
Oh, here. It's okay. I got it. Oh, that's not 20. We better not do 20. We better do 10. Okay, so I'll put it up here, and I got it. I got it.
Okay.
So we'll do to 12:35, you guys, okay? That's on. Well, before I do that, I should always take my camera off. You're already sharing our phone.
Battery 40%. Connected to Uni's iPad.
Okay, you guys. Let's see. Everybody back? I need to get a roll. Okay. All right. Signs and symptoms, shaken baby syndrome. You guys have had OB. What would this look like for a newborn infant coming in the ER? What are we going to see? Okay. What are we going to see? Oh, it's just, why does it do that? Okay, listlessness, yes. Not responsive. Increase, yes, definitely. Seizures, respiratory issues. Lethargy, poor feeding. With the intracranial pressure, what will we see? Because really, we can just, this really kind of goes with your cognition, doesn't it? Signs and symptoms of increased pressure. So with our kiddos, this normally happens between bulging fontanelle, yes. That's a big one. Hard to arouse, yes. So really this kind of fits on, it's two things happening at once. So the abuses happen where the parent or whomever has shaken the baby. And let me put my camera on, I'm sorry. You know, like talking to a small screen. Where is it? I got too many things open. Okay. Oh. Stop it. Come on. This is going to be a semester with technology.
Absolutely.
It won't do what it's supposed to do when it's supposed to do it. I'm getting a new computer after this. I'm telling you, this computer right here.
And what would I do with that, Miss Gordon? Yeah.
Okay, hold on. I'm going to stop sharing for a minute because it's got too many things going on. Come on. There we go. Gee, just to get to that on. And I have to start all over again? Are you kidding me? Okay, so we got two things going on. The parent has shaken the baby, and you guys know it's about this much space in between your brain and your skull, right? So it just wouldn't take much for this baby to have injuries and etc. And when we're talking about when they shake these babies, so time frame for an infant or for it to be shaken baby syndrome is between 2 to 3 months or is it up to 3 months? Correct. You might have to help me with that. I'm not drawing a blank right now. That's great.
I think it is 2 to 3 months, and even I think you can even have shaken baby even up to 18 months. I think really. So I think it's interesting that in the discharge planning for our babies that they're including shaken baby syndrome because it's so common.
Yes, it's like that because they're shaking the baby violently. It's just like and the baby's head is already unstable, right? I mean, it's for it to just come out with traumatic brain injury versus a broken neck is and which I think happens sometimes where you get these cases. They say they found the baby dead when they're trying to cover up their crime or whatever, and then they then found him unresponsive. But of course, the investigators and all that could see the trauma, the blunt trauma, either to the head or just. I think some neck breaking goes on for these kids, these babies too, when they're that little, and their necks are just so vulnerable. So
it's heart-wrenching. It's heart-wrenching.
Oh God, don't even. Yeah, I can't even. And we see that in the news. I probably have seen one a month over these last couple of years. It's like, oh my God. And then parents, that's where we would have to do parent teaching when you have these people releasing them from hospitals and whatever. Do they have good caretakers? Because sometimes parents, they think they trust the person and they've left this child with someone that can't handle taking care of a small infant or a child, and that's where a lot of these cases come from. Or they're just angry at the other person and they take it out on the kid or the baby.
That's a good point. That's a good point. Sometimes it's the caregivers, yeah. Even in nursery and even in daycares, there's been cases of that. So, shaken baby.
Yeah. So, okay, we got two things going on. We did the physical injury, and then that leads you to your cognition piece where we got intracranial pressure and the traumatic brain injury, etc. with this infant. So you will see these signs and symptoms of the baby. Have there been some that recover? No, most die. They are dead before they even get to an ER. But there have been recoveries because there are miracles that happen every single day. Every single day. So somebody had mentioned respiratory distress. So of course the brain center, the area of your respiratory function in your brain, yes, can be affected. And so these babies have, so it's a dual problem, neurological and respiratory stemming from that. So, but the neurological problem happens first. I think most people go to the breathing, but they're only having the breathing problem because of the neurological problem. So really read that, understand that. I think we have had a lot of confusion around that because they have both issues going on. So they have more neurological issues, and then that leads to your respiratory issues because of the respiratory center in the brain. All right, bullying, do we really need to talk about that? I think you guys know what to do with bullying, right?
They can read what they need to read in the book. I don't think we need to spend any time on it. We don't have much time
and
left.
I won't ever remember many questions on the test, which I know y'all always ask, so I will be the first to always tell you of what, not that they can't find one and not that they can't make one up, but I mean, really bullying is just a matter of talking and trying to keep these, and bullying is not only coming from physical bullying where the big bully is beating the kid up every day for his lunch money and that kind of stuff, but we can add cyberbullying in there. That is huge. That is
the cyberbullying is really huge right now. There was a kid in, I don't know where, some suburbia, and that he was cyberbullied so much that I think he was like 11 or 12, and he committed suicide because of this cyberbullying.
So then there we got to talk with parents about protecting their children online and all of that. Some of you got kids, so I know you know what to do with this whole bullying thing. And if we suspect it with our kid, and if we can get them to open up and talk with us, because there are kids who have killed themselves as young as 9 years old. There was a recent case here in the Dallas-Fort Worth area, really. That kid was bullied. He was a 9-year-old kid. So we have to remember that kids today are far ahead of where we were at ages, even you guys. Your kids are way ahead of where you were at certain ages, and it's like, how could a 9-year-old ever think about hurting himself? Well, they see stuff in cartoons and all kinds of things. So just talk with your kids, and if they divulge anything about bullying, etc., you get to that school or have parents have these conversations, and schools need to work harder at this whole bullying thing too. But cyberbullying, that really has to be kind of a parent thing, really, because these kids are very savvy with this media and social media and technology and all that stuff. And we never know what they're getting into unless we got to be willing to pry.
Yeah, and it's a team approach because it has to be the school and the parent and the child too. So it's a team approach. It can't be just one. If the school is not involved in that, it becomes more difficult.
Exactly. All right, rape and trauma, huge. And that's exactly what it is, a trauma. Rape is one of those things that if you encounter them in an emergency department or ER, it's nothing you can say or do that is going to take away that. So you really become the protector at that point, because if it's been reported a rape, or let's just say the police got her to the hospital or whatever, they're going to want to interrogate her or him. Rape can happen to anybody. It could be a young child. It doesn't matter. So you, the nurse, got to be willing to protect them. First of all, you're being present and silent maybe until they're ready to talk, because what do they do when, or even if it happened to me, what would I do? What would my brain do? It would be to every time I have to talk about it, I'm experiencing that trauma over and over and over again. So
re-traumatize and re-traumatize.
Yes. You want to protect them for that. If that policeman say they need to talk to them, it's like you're going to have to hold them back. It's like, she can't talk right now. She doesn't even want to talk. So you're going to have to kind of be that advocate for that person. I really had a good PowerPoint for this that had all the points in there. I've lost it, or I don't know where it is. So if I find that, I'm going to send that to you guys too. But you want to offer to call their family or for someone to be with them if they want that. But what is going to happen 9 times out of 10? I see a hand up. Let me put this down here. Who was that? Whose hand was up? Did somebody raise their hand?
See it.
I didn't raise my hand, but I had a question actually.
Okay,
go ahead.
In terms of the trauma thing, isn't like with trauma, you're supposed to like process it and integrate it though, so you don't end up with PTSD though, right? Or is there like a certain setting where that's better to do than just like in the office?
right.
Most people that have rape do have post-traumatic stress. So it's a process. It's not just a one-day event. So even though they've been traumatized, it's very common to have post-traumatic stress after that. So again, it's therapy, very intense therapy that helps them get through that and maybe to ward off some of the post-traumatic stress. Good question.
Mm-hmm. And, and it might take some time to get there. They have to get over the initial trauma and the physical trauma. Some people have been raped at gunpoint and knife point, and it's a process to get them there once they get to that therapy. And yes, they will definitely have PTSD because it's traumatic. And, they would be fearful of people. They might not want to stay in their homes or wherever this happened. They might want to avoid that area, or it's a lot of things that is, because PTSD is the same thing. They're reliving whatever happened. If I was hurt in a bomb, every time I hear a loud noise, I clench or jump or think I'm there. So, our war veterans are big ones for PTSD. So they relive war a lot in their heads.
I was hearing on the news last night that the human trafficking, the human sexual trafficking was like 100,000 people last year. That's a whole lot. And I think the children involved in that were maybe like 70,000. So it's very, very, very common. Not only just in the regular everyday, but into sex trafficking also.
Yes, that thing is growing. It's really growing. And they'll take anybody, really. Women, men, children, they don't really care. They're just something I was reading. I don't know if it was in the article I was just reading, which was I was trying to find the most up-to-date research or whatever. And it gave the story of this mother. She needed to pay $250 and she sex trafficked her 5-year-old child. It's like that just like gripped me at the core. It's like, this is bad. This is really bad. I don't know what else to do with it. It's just really bad. I don't know what to think. I don't know what to do, but I want to hurt people. And I wish
evil.
that
It's evil.
It's very evil. Okay, so all right, hotlines for rape and those things. Usually, I always talk about trying to get the person in for the testing, rape kits and et cetera, if we will, especially if they want to prosecute, if they can find the person by DNA and all that stuff, because and you want to use your therapeutic communication so much so that you can try to get the person in without doing what thing? What is the first thing a person is going to want to do after being raped? I saw a hand, I think, again.
Absolutely. That's the answers.
Yes.
Absolutely.
They are going to want to bathe, shower, and whatever. They want to wash it off. They feel dirty and violated and all of that. So, but if they wash it away, what hope do we have for any kind of prosecution or finding a person if he's a serial rapist or something like that, if the evidence is washed down the drain? So you have to kind of help the person work through that and get there, and then of course we can get them cleaned up and start that healing process, which will be a long process.
So sometimes in the major hospitals we have SANE nurses, sexual assault nurse examiners.
Nurse examiners, yeah.
Yeah. So, and if you work in a smaller hospital, you can request to have a SANE nurse come into your smaller hospitals because they're used to dealing with these people every day. They know how to best deal with it and get evidence and get them in the right spot to get help.
And more, that's becoming a big area for nurses as well. So, nurses can get certified in that. It's not like you have to just like go into that, but you can be certified in it and maybe even do it as consulting or whatever. So, but it takes a high skill to be able to work with them, and you got to know your own awareness. So when working with mental health, awareness is key. So on all of these things, I want you to go in your book and look at the awareness that you need to have with each patient. Because there have been times that we have tested the awareness that you need to have. And if I haven't read that, then it's like, oh, I don't know. So most of the time it's just about keeping boundaries when the patients are upsetting us so much, or they're in the hospital all the time, they're always creating problems. So there are times that we might want to choke them. It's like, you know what, if he said that one more time, I might want to. So I have to check myself, because you guys would think it's about not being biased or whatever. It's like, no, it is about you checking yourself to make sure that you can treat the patient therapeutically, because you need to check your own feelings about how you're feeling right now. And so that would be the same for rape and trauma. Probably to be a sane nurse, you're going to have to check yourself. It's just like we need to do for death. How do I feel about death? Can I work in hospice if I can't handle patients dying every day? So the same nurse would need to do the same thing. All right, you guys, so we're going to move on to personality, because we got to spend some time on schizophrenia and postpartum. So this was on TV, but it is a thing for people who have been raped or gone through trauma.
Move forward. So psychosis is psychosis, whether it's a psychosis with a schizophrenia or psychosis with a postpartum. Psychosis looks like psychosis. So, and the whole main thing is, again, safety, how you're keeping these patients safe, whether they're hallucinating because they have schizophrenia or they're hallucinating because they have postpartum depression. And I'm seeing more and more incidents of postpartum depression. I'm not sure whether we're just admitting more or whether people have more postpartum psychosis. So, but in the last few years, I've seen a great increase in the incidence of this.
Yes, and it's happening, and it happens to, again, that's one of those things that it goes across, excuse me, it goes across cultural lines. There is no thing to say that one person gets postpartum psychosis over another. I saw a hand, I'm not sure who it was, but now we didn't talk about the personality. We can come back to it, Ms. Gray, if you want, but we can talk about postpartum psychosis right now. So it's called postpartum psychosis because it happens after the birth of the child, within, sometimes immediately, sometimes within 2 to 3 months. That they can still experience it. So, what signs and symptoms would you see? I've heard of Stockholm Syndrome, but that is usually attachment to perpetrator. Are you guys still talking about rape and trauma? Are these questions for us? Maybe I should ask that. Are these questions for us, or are you just talking?
It's a question. I'm not sure what that is. Let's just move on to psychosis, and yay, but not a big deal. To who? For what? You can move on. Okay, let's move on. She said move on.
All right. So the big thing about postpartum psychosis, and we got to come back to personality disorders because they have it up under interpersonal, but we'll come back to it after this postpartum psychosis. So, and I did have a PowerPoint for that somewhere in it. And this is very general, just because I know you guys like to look at things sometimes. So we'll put it up, but we'll just talk. And we can send you guys all of these, or y'all have them. Did y'all find your PowerPoints up under week 3? That's because we used to do it week 3, but now they keep moving it to week 2. So they just didn't move them around.
So what we need to do with postpartum psychosis, we need to keep the baby safe and the mother safe. We would never leave the baby alone with the child because they are hearing voices, and so the child is at risk for harm, and the mother's at risk for harm, but mostly particularly the baby. So the mother needs to have supervision all the time she's with the baby.
And the signs and symptoms you will see is just no attachment, really. They are, if you pick up on this before they take that baby home, and that's very important that you catch these red flags before you leave that hospital, before they leave the hospital. But sometimes it's not possible, but we have to teach our family members to watch for them, because sometimes they're seeing things and just overlooking it, and you know, if they're not forthright. I have a coworker that, you know, their daughter, you know, called them up one day and going like, you know, I just not sure I love this baby, and oh my God, it's like, what? So the family have to be able to pick up on the cues. It's kind of like suicide, you know, the person is giving cues all the time, and family members are missing it, and then they find the person hanged. So in this case, they find the baby self-harmed, put in an oven, or God told them to sacrifice the baby. So this happened not long ago over in Carrollton. He said God told him to sacrifice his baby. He put the baby out in like 100-degree temperatures, left him laying on the lawn of the apartment complex, you know. So just watching for these signs and symptoms. And then, I mean, even over in the Fort Worth area, this mother killed her kids, and she was married to a very prominent pianist or something like that, concert pianist. And just come home one day and the kids are dead. The kids are dead because this lady is having, a psychotic breakdown, basically.
Mhm.
So a lot of this stems from most of the research is saying that when people have that postpartum psychosis break, that they had underlying bipolar anyway. And for bipolar, the depression that people have in bipolar, besides the mania, it's a very disparity kind of depression. It's a deep, deep depression. It's way beyond just kind of like major depression. So they've had those underlying things, and then after they have this baby, and between all of the care and expectations of raising the baby and maybe feeding and breastfeeding, it just causes that break to happen. And they hear the voices and the see things or whatever, mostly hearing voices telling them to do things. You agree with that, Miss Gray? You got anything else to add on
I
that?
do. I was trying to think of that lady's name that killed her 4 babies, drowned them.
Darlene Rainier, probably, or Redier, or something like that.
No.
Not that
Anyway,
one.
she drowned her 4 babies. The devil was telling her to drown the babies. She had postpartum depression. What was her name? Can't think. It doesn't make any difference. She drowned her 4 babies. Andrea Yates, exactly. Andrea Yates had drowned her 4 babies. Yeah, that's correct. So sad.
So key point is safety. If you're seeing them in the hospital, or if they come in for a follow-up visit and you're noting they're just saying they're not, wanting to care for the baby, and you're just picking up on all these clues, we need to get with the family, come up with some planning, and just have supervised visit with this mom, whether it's in the hospital or whether it's at home or whatever. She just needs to not be alone with the kid at all, the baby at all. Okay, any questions on postpartum psychosis? It's not a lot to that. They don't ask a lot of questions on that. NCLEX don't ask a lot. That's what's important.
I think
Good?
we're good to move on. I think we're good to
Okay.
move on.
So let's go back to personality and finish those, because you guys had a video on those when you had to watch them for coming to clinical and getting your certificate. So Ms. Gray, you can go ahead and start talking on that.
Okay, so let me just tell you, it's just in capsule regarding personality disorders. What you have to know is that all the other diagnoses we have are what we call Axis 1. They're a medical diagnosis, but personality disorder is an Axis 2. And when we have an Axis 2, medication does not touch it. So in other words, you can't have someone that's bipolar. There's no medication that you can give them because it's an Axis 2. So personality disorders are definitely odd and bizarre. They just are odd and bizarre, but they all kind of group together in that you have to confront the behavior. These people are very manipulative, particularly the borderline behaviors are very manipulative, and they will run a whole unit. So you have to really work on that team approach. We talk about team approach a lot, but that should be in med-surg and psych and neonatal and adolescents and children and everything. So anyway, with all of these, we just there's so much similarity, and so kind of when you go through them one at a time, when you get to the end, you think, well, I understood that, I understood bipolar. I mean, I understood borderline, I understood antisocial, I understood all those, but then they all begin to kind of blur together, and then you probably have understood personality disorders because they all do blur together. So you just have to remember that there's not medications that you can give that help these, because they're axis 2, but many times people that have an axis 1, many times people that have a bipolar disorder or they have a schizophrenia, they may also have an underlying personality disorder. So even though you're treating the axis 1 of the psychiatric medical diagnosis, we are not treating the personality disorders, but they go together a lot. So you know, they're a clash with society. That really kind of probably says it all. These people do not fit well into society. They clash with society. So that's what we like to think about with that. And I'm not sure how to move that down. Personality disorders.
Yeah, I'll put it up.
That's what I need to tell you. Personality disorders are an enduring, long-term. Can you go back to that other unalterable? Okay, right there. When the personality traits are enduring, they're an enduring pattern that becomes so rigid and maladaptive that they become dysfunctional. So it's not just all of us can look at ourselves and say, oh, that was kind of borderline behavior, or that was a little antisocial, or whatever it may be. But that's not what we talk about with personality disorders. What we talk about with personality disorders is there's a long enduring pattern that becomes so rigid and not adaptive that they become dysfunctional. So when we look at that, so they must track over a historical continuum of time. And so the real issue with this is that in order to really get an absolute personality disorder diagnosis, you have to go through a huge series of tests. So because they're expensive, and most people don't do that. Someone that maybe that's at Terrell for 3 years may have done a personality disorder. They may have done some personality disorder testing, but basically the physicians just determined by some of the behaviors that they probably have a personality disorder of borderline or antisocial or paranoid or whatever it may be. So, but it's not really very absolute. So that's kind of thing. I'm not crazy. It's just my reality is different than yours. So again, medications never treat because they're on axis 2, and they are just a behavioral. So the only thing that really works is behavioral treatment programs, long time behavioral treatment programs. And so what do you know about these people? They're non-compliant, and so consequently it's hard to get treatment. And these disorders are clustered together because they have similarity and overlapping. So I think, you know, you can look at all these different clusters, the different ones. I think it's not important to try to memorize which cluster they go into, because that's not what NCLEX is going to test you on. HESI is not going to test you on that. They're going to test you on those behaviors and what kind of intervention that you need to do. And the main thing you need to do is to be consistent. You have to have teamwork and be consistent, and not let these people manipulate them, because the whole group of personality disorder is very manipulative. So what questions might you have on personality disorders? I kind of flew through that, but anybody have questions?
Who remembers the 3 clusters that was talked about in the video? I know some of you, Miss Grace's group, haven't watched it. She will get with you guys so you can go watch those and get your certificate to bring to her for clinical.
And that's good to look at the clusters, but I don't think that will be, it's a good way to kind of cluster the thoughts together, their behaviors together, but I don't think NCLEX or HESI is going to ask you to identify which clusters they're in. That's just more specific than what they're looking for.
Right. But each cluster, I think it's important to know the kind of behavior they have. Like these, if we talk about the cluster A, which is odd and eccentric, then these tend to, all of them have paranoia kinds of things, are avoidant, they're elusive. So you know the signs and symptoms basically of the cluster. And like Ms. Gray said, how to care for that cluster of patients. So your B, which is, I know it's in here somewhere. I think I have a PowerPoint that just
It's there somewhere. It's up and down.
that does probably the one that I did the thing over. But B is like your this PowerPoint is too much. Antisocial. No. That fits in your, here we go. Cluster B, which is dramatic. So that's where your borderline is. This borderline is a commonly tested personality because they are more prolific, I would say, than the rest.
Absolutely.
So,
that's probably where your question would come from, is from borderline. Mm-hmm.
Yes. So if anything, I would know that.
Because they're so manipulative, and the percentage, I think the percentage is 65%. I want to say 65% of the population has some tendency to borderline behavior. So it's very common, and I'm sure if you don't know some of those little signs and symptoms you may be having yourself, you may know family members or people that have borderline personalities. Sometimes they say that borderline is dancing backwards in high heel shoes. So that pretty much kind of says it all. They're just not very stable, and they're not looking forward. They don't look forward. They don't look behind. They just dance in high heel shoes backwards.
Right. And they are very dramatic. They're very dramatic. They create more havoc. Their biggest defense mechanism is splitting, where they will love something once and hate it the next, and they will love you for the minute and then they hate you. And they dramatize everything. It doesn't matter what it is. They're very dramatic. Narcissistic, you guys know what it is. They're so into themselves. They love themselves and they do everything right and just all of that kind of stuff. You guys do have good mnemonics on these if you want to watch them. In your Bruner book or one of your books, you have great mnemonics available free for you in your own electronic books. So I would watch the borderline one and know their personality and how they function.
Narcissistic he was the guy that saw himself in the pond. But back to the borderline, borderlines have multiple hospitalizations, multiple marriages, multiple fathers of their children. They have multiples because they get themselves in awkward positions. So this right here. That's narcissist looking himself in the down is the other way.
Yeah, I was trying to just find
this right here. I love this right here. If you look at
what right here?
No, can I do it myself? Can I do it over here? No.
No. Which one you want? Which one?
That one. I love it. Hate you.
Splitting.
Splitting. Let me talk about splitting, and then we'll talk about I love it, hate you. So this is a book that's out that just pretty much says it all. I hate you, don't leave me, and that pretty much says it all. So how much time do we have, John? Oh, we just
not a lot.
Not a lot. So I can't tell my stories. I can't tell my clinical stories, but borderlines, they split. So this reason you have to be really have a team approach, and this goes for families too. They say that toddlers and adolescents are just developmentally borderlines, and so there's a lot of research that says that if you are as a toddler have some of these things and that are not addressed, that you will tend to be a borderline as time goes on. But adolescents, you know how they do. They split mom and dad and whatever. That's a normal developmental thing, and you hope that they mature and outgrow that, and that's not how they continue on in life.
Okay. You guys can read this or go back on that. It's just we're running out of time. I had some questions to just kind of check your understanding, just to break this content up a little bit. And it's 1:13. I don't want to hold you guys over. The schizophrenia stuff. Sorry.
Go ahead. Go ahead. I was just going to say nursing interventions set limits to provide consistent limit setting. That's it in a nutshell. So let's go ahead and move on to schizophrenia.
Well, then we just want to hit the basics about this. I normally have you guys do a little group activity at this point, but we're not going to have enough time. To definitely not hold you guys over. So for schizophrenia, for the most part, you definitely got to know signs and symptoms, and which you guys have learned a lot about in your actual clinicals, in your actual what you've read about, you've looked at those PowerPoints for the certificate and all that stuff. So basically knowing the difference between negative and positive symptoms. Your hardcore symptoms, and I'm going to send you my notes basically. I didn't pull them open or up. And then the medications that we use to control that. So we had some, so when they're taking these hardcore medications, we have 3 types of medications after you know the signs and symptoms. So, and the medications, some take care of positive, some take care of negative, some take care of both. So we have, So
when we talk about the positive symptoms are the ones that are more commonly seen, like the hallucinations and delusions and paranoia. But that's kind of a strange misnomer. Positive symptoms are not really positive symptoms. That's just how they labeled them. And then they went to another labeling type thing. But it's just important that you know that. So the old medications, the first generation medications, spoke very specifically to the positive symptoms, because those are the ones that were preventing people from getting into society better. Then the negative symptoms, sometimes if the medications prevented them from having delusions and hallucinations, they still could not even work at McDonald's because of the negative symptoms. And those negative symptoms are when they're so isolative and apathy and indifference and lack of motivation, anhedonia, the things that they just don't like anything anymore. So as our pharmaceutical interventions have improved, then our medications also have addressed these negative symptoms, because just addressing the positive symptoms only addresses part of the issue. The negative symptom is only part. So now we really are seeing that most of the medications, the newer medications, the second generation, the atypical medications are addressing both of those, addressing more of those, both negative and positive symptoms. So the old medications, the ones that just, when they came on board in the 50s, I don't know we're going to have time for Idabel or not, but they addressed aggression and agitation so well that we just gave those patients more and more and more of that medication because it did so good, and they ended up with tardive dyskinesia, which is totally irreversible, and it is so sad. So sometimes when you see people on the streets that are shuffling their feet and they're rolling their fingers and they're smacking their lips, that is not a symptom of schizophrenia. That's a symptom of the medications they're taking, which is so sad. And so why would anyone want to take medication that made them feel like that? So then the second generation came along with the Clozaril and the Zyprexa and the Seroquel. So some of those new medications, the Risperdal, some of those new medications were certainly helpful in addressing the negative symptoms. And now we do have third generations. One of the more common one is the Abilify. I like Abilify. I guess I just like the way it says Abilify because I think about that this medication gives these patients, this population, the ability to really function better than what they've been able to do before. I'm sorry, I didn't hear the question. Was there a question? I missed it.
Does somebody have a question?
Maybe not. I'm just spinning through this. Okay, so what is tardive dyskinesia? So that's the pin rolling. Actually, it's interesting. We're seeing some of that on some of the news and advertisements, which I think is interesting. So it's a Parkinson-like. Yes, it's very much like a Parkinson. They shuffle their feet. They pin roll. They smack their lips. These are kind of milder symptoms, the ones that we're showing you right now, but there certainly are some very serious ones. But for the most part, we don't give patients the huge amounts of the antipsychotics. And see this guy, how he's pulling his back. That's pretty common, and so you really have got to address that with some medications. So Cogentin is one that we can use. Benadryl works better. It's less invasive than the Cogentin. So if the Benadryl is not working, then we can give the Cogentin. I would never accept a doctor's order for a antipsychotic medication that I didn't also get a order from either some kind of Benadryl or Cogentin. But we give those medications all the time. Haldol is given like candy in the med-surg areas, and we don't use these other medications that we should be using as kind of a salt and pepper. Okay, here's Annabelle, so let's watch her. Okay, what's your question? Jessica, what's your question?
Okay, no God. Okay, very good. Okay, do you wear ditches? I don't see that you have it in. Okay, you do wear them, but you don't have them in. Okay, very good. Annabelle, let me ask you a question. Have you noticed the movements, any movements in your mouth and in your face, or in your hands, or in your feet? What kind of movement? Any movements that bother you at all? None that bother you. Okay, they asked you to, can you sit back? Okay, very good. Now, Annabelle, can you relax and put your hand on your knees like this for what? Okay, I just want to see if you can kind of relax and just place your hands on your knees. And your feet are just fine. Can you put your left hand on your knees? Yeah. Okay, just like this. Okay, shall I help you? Okay, very good. That's what, oh, it's tender. No wonder you're holding it. Okay. Okay, if you put the other one just on your knee, that's okay. Can you put them both at the same time? Okay. Okay. Now, can you do this, Annabelle? Just relax your hand over the end of your knees. Can you do that? No. Okay, can you try that? I know that hand is tender, but just relax them over the edge of your knees. Will the left one relax like this? Okay, can you do that? Maybe I could. Okay, well, you're ready for what? Would you try? Just want to see if they kind of relax and hang, or if there's any movement in your hands. Can you try that for me? Yeah. Okay, would you sit? Okay. Okay, look at me a moment. Okay, let me ask you, can you just open your mouth and hold your tongue like this? What?
I see her. You see her tongue? We call that snaking. You can see her tongue snake.
Okay. Do you want to watch the whole thing, or we kind of
No,
short?
that's
but
fine. That's good.
You
So,
got
but this
exaggerated movement,
absolutely.
and
So
her
if you see,
entire body is involved, not just one part.
So if you see Ida Bell, you should not forget thyrodyskinesia. It's absolutely amazing. But Ida Bell probably was maybe looking at her age, probably started getting some of the typical antipsychotic drugs, and because she was, you can see she is not cooperative. So even now, so they gave her more and more and more. So when they do that, thyrodyskinesia is irreversible in the synapse. You can't reverse it, and that's the sad part about it. It is totally irreversible. So they're just living with what they live with. And you know, it's amazing. They ask her, do you notice any movement in your mouth, or no, or your tongue? No, she doesn't. It's so common. If there's one thing that can be looked at as happy about thyrodyskinesia, is when they sleep, it goes away. I cannot explain that to you. I don't know that reason, but it is when they sleep, those movements go away, so their bodies are able to rest. And when you look at Ida Bell, her little legs were like just little pencil legs, and her arms. And why is that? I'm going to answer my own question. It's because she has non-stop movements all day long. It uses an enormous amount of energy and calories. Questions? I'll field questions the best I can. Yes, Rachel. Rachel, what's your question?
Can you speak to the haloperidol, if you can give it IV? I'm getting conflicted information if it can be given that route. And also with a lot of the psych drugs, I'm seeing something about a prolonged QT interval as something to look for. Is that correct?
Sometimes we see that. Are you asking the route of Haldol? Is that what you're asking? It can be given orally, it can be given IM, and it can be given IV. Does that answer your question?
And Lippincott, no, yes, for short, no, because Lippincott says that it can be given IV. In the text, Lippincott advisor says do not give it IV, and then the FDA says do not give it IV.
Okay. And I have rarely, if ever, seen it given IV. I see it given orally, and IM very frequently. So I would say 99% of the time, this is the way it's given. And they're changing all the guidelines for some of these medications. But and see, look right there. It's see how they called it a tranquilizer. So that was what happened when they first came out. They called the classification of these drugs, they called them tranquilizers instead of antipsychotic drugs, because it did calm down people's aggressive behaviors and whatever. So it's not a tranquilizer, but that's how it was first labeled. It was the first, but it's not a tranquilizer. It's an antipsychotic drug, which works on different levels. So did I answer your question?
So relating to Rachel, I'll just add this for testing purposes, even for NCLEX, and Haldol is the most commonly tested. So just understanding that for the most part, we give it IM so that we can give it, to help with compliance, we will give it this decanate form, which is the intramuscular injection. So I would go more on the oral, whatever side. It has to be an extreme case, probably very extreme, for it to be given IV.
I'd agree. But when it's given IM, it's usually given, particularly if it's aggression, it's usually given in combination with Benadryl and Ativan. So that's kind of the cocktail thing that works the best. But again, you see that the Haldol is given with the Benadryl because they're both I can't think. They're both antihistamines, so it causes those kinds of same symptoms with that. And then with the Ativan, it works very well for people that are basically out of control and agitated. Okay, other questions?
Thank you.
You're welcome. We're out of time, so.
Almost,
but we're here.
Yeah, so I will be sending a lot of you this information. I'm going to send you all of these information. You can, we'll field any questions that you have later. Just send us an email. You know, we'll definitely respond. I love these little memory cards because they just get to the point. You know, sometimes if I see this picture, I won't ever forget, you know, whatever it is on there. It's just because I'm very visual, so those very visual people. And then I love these little memory cards because they get to the point of what you have to know. If NCLEX or we were going to test you on anything, this is what we're testing you on. One big thing for Haldol is you have to, this is a major side effect problem, this agranulocytosis. And if you guys know what that means your white blood cells are being decreased to nil. Even further than what cancer would do maybe. So we really we have to do lab work with these drugs to make sure that they're not getting into agranulocytosis, and then of course they can become septic and get all kinds of other problems because of this side effect, but if not kill them. So anyway, here is how they will get the labs drawn more frequently in the beginning, and then we kind of taper off. To monitor that. So as a nurse giving these drugs, you'd have to know that. And those are commonly things tested. So please know them relating to this drug. That it's the only, and Haldol is the only deconate one, correct? None of this third generation is, Ms. Gray, right?
I'm sorry, I didn't hear the question.
Any of the third generations that are deconate form that can last over a longer period to help patients be compliant?
There are some long-acting medications, Haldol deconate, Prolixin deconate, that are given IM that last somewhere between 2 and 3 weeks. So those are usually given in the clinic, and it helps with compliance. So,
but those are early generations. I was just thinking of some of the newer ones. I was just wondering because
there are some new ones on the market. I'm not really familiar with them, but there are some new ones on the market that are long acting.
Okay, so but guess what? They're not going to be on NCLEX because NCLEX is not that far ahead. So this
they won't be on NCLEX.
Yeah, this is what you're going to get for NCLEX and our test purposes. Okay. All right, so I will be sending you things. We did the questions that I had to do the little interactive activity. I will send those to you guys as well as additional questions. But other than that, do you have any questions? And I hope that you have gleaned something from all of this. You probably knew more about it than you thought you did. But let's see. Let me stop sharing here. I'm going to send you my notes that covers all of it, including nursing interventions on all of it and key points, the need to know key points for all of it. So that should make your preparation better and make you feel better. I did that in the past, and students, I just captured what is most important, even for NCLEX. Remember, you don't ever have to know it all. You don't. But you got to know the basics to be able to answer. If you know these few points, there should not be a question that you cannot answer relating to this psychological stuff. Okay, I'll stop sharing here.
Any other questions before we sign off?
Okay, next class will be, TBI and encephalopathy. I know the schedule is weird, but we're still covering we're still covering cognition and interpersonal. So we did the interpersonal piece. Miss Reljak will finish up with the cognition, and you guys will have an exam. So like last semester, I recorded the lecture. Shoot me an email at, oh, okay. So Thomas, do you have a school email?